Anterior jaw test. Place the patient's ankle in full plantar flexion. Apply slow push on the tibia posteriorly while the other hand is stabilizing at the talus. This tests for the stability of the anterior deltoid ligament, the ATF, stability of talocrural, as well as the distal tib-fib joint and avulsion fractures. You're looking for rotation, excess motion, or a clunk at the ankle. Let me know if this reproduces your pain. Anterior talofibular ligament test. This stress test, you put the patient's ankle in plantar flexion, inversion, and you apply pressure over the ATF. Let me know if this reproduces any pain.
Patient is in long sitting with a towel roll under the ankle. The foot is placed into dorsiflexion, and the practitioner places posterior pressure on the talus.
All right, I'm going to apply some pressure right here on your ankle. Let me know if it causes any discomfort.
Patient is in long sitting with a towel roll under their ankle. Practitioner applies pressure on the bottom of the great toe.
I'm going to apply pressure right here on the bottom of your toe. Let me know if it causes any discomfort.
MCL stress test of the knee. Secure the patient's ankle and place the other hand next to the fibular head. Push medially at the knee. This is causing valgus stress and will test the MCL stability as well any reproduction of pain. Let me know if this reproduces any of your pain. Anterior jaw test is a stability test for the patient's ACL. Knee should be about 90 degrees. Place your hands around posteriorly and draw the tibia towards you. If there is movement of the tibia, this could be a torn ACL. All right, let me know if this reproduces any of your pain.
While the patient is supine with knee bent, practitioner performs posterior tibiofemoral glide by placing posterior pressure on the tibia.
I'm going to apply some pressure. Let me know if this causes any discomfort.
Practitioner performs Faber test while the patient is supine in a figure 4 position, placing pressure on the medial knee.
All right, so I'm going to have you bend both of your knees for me. Now we're going to place this foot over here. And then let me know if this reproduces any of your pain.
You got it.
Practitioner performs Ober test to assess ITB tightness. The patient is in side-lying position. The hip is lifted into abduction, external rotation, and extension with the knee flexed. Practitioner releases the leg. In the supine position, practitioner performs lateral distraction of the hip using a belt.
Let me know if this causes any discomfort.
In the prone position, practitioner performs PA pressures to the thoracic and lumbar spine in order to assess for pain, stability, and mobility. This can also be used as a mobilization.
All right, Natalie, I'm going to apply some pressure to your back. Let me know if this reproduces any of your symptoms.
Yep.
Right there. All right, I'm just going to hold some pressure there for a minute.
Lumbar side flexion mobilization. The patient should be in side lying. The clinician's one hand comes around and stabilizes as the other hand is imparting flexion at the lumbar segment. This is opening up the facet joint, and this could relieve symptoms of the patient's radiculopathy and pain. Let me know if this relieves your symptoms.
In the side-lying position with knees flexed to 45 degrees, practitioner applies a downward pressure through the supinated forearm to the iliac fossa. This can be held for an extended period of time to allow the sacrum to reset itself.
Alright, I'm gonna apply some pressure here, Natalie, if that's okay. Just let me know if this causes any pain or anything, okay?
Okay.
In the supine position, practitioner crisscrosses their arms and places the heels of their hands on the inside of the ASIS. Pressure is applied outward to compress the SI joint.
Alright, Natalie, just let me know if this reproduces your symptoms, okay?
In the supine position, practitioner performs cervical spine compression and distraction to determine if this makes their symptoms better, worse, or the same. Let me know if this is better, worse, or same.
Same.
Okay. Better, worse, or same?
Same.
When performing the Sperling's test, patient is in the seated position. Practitioner guides patient's head into side bending and extension and may cautiously add overpressure. This test is positive if the patient's pain is reproduced.
Alright, let me know if this reproduces your symptoms.
No. Yeah. I feel it down my arm. Cervical mobilizations. For inferior medial posterior glides, come around posteriorly on the patient's cervical. Apply inferior and medial downward pressure to the patient's opposite hip. This will restore facet extension. Another cervical mobilization is cells. This is when the clinician uses the second MCP of their hand and rotates the patient's cervical superiorly, anteriorly, and laterally, gliding the facet. This is restoring facet flexion.
In the standing position, patient's arms are positioned in the scapular plane of internal rotation and 90 degrees of flexion and abduction of the shoulder. Manual resistance is then applied by the practitioner towards the floor. This test is positive for a supraspinatus tear if pain, weakness, or both are produced. Alright, have you turn your hands in, lift your arms up. Does that reproduce your pain?
No.
Alright, now apply some overpressure. Let me know if this reproduces your pain.
Yes.
Painful arc test. The patient is instructed to perform straight plane abduction and internal rotation through full range of motion. It's positive for impingement if pain occurs between 60 and 100 degrees of abduction.
Okay, so I'm going to have you hands out, thumbs up, raise your arms overhead, and let me know if it reproduces your pain. And back down.
Anterior apprehension test. Have your patient supine. The PTA passively abducts and externally rotates the humerus. Positive findings are if the patient feels pain at the anterior aspect of the arm along the biceps brachii. Lateral distraction of glenohumeral joint. Have your patient supine. PTA sits near the affected shoulder, abducts the shoulder slightly, and gently grasps the proximal humerus and directs a straight lateral force, translating the humeral head from the glenoid. Posterior glide of glenohumeral joint. Have your patient laying supine. PTA sits near the affected shoulder with the shoulder biased towards internal rotation. With the heel of the mobilizing hand, apply a posterior glide to the proximal humerus
with pressure towards the table. AC joint mobilizations. Have your patient sit at edge of bed. PTA will stand or kneel behind patient. Stabilize the clavicle with one hand while grasping the acromion with the other. Mobilize the acromion in an anterior-posterior fashion around the end of the clavicle. For tennis elbow, you would manual muscle test extensor carpi radialis longus and brevis. To do this, have your patient sitting with their elbow flexed and forearm fully pronated and supported on a table. Support the patient's forearm and extend the wrist, then apply resistance at the base of the second metacarpal for longus and third metacarpal for brevis. Apply pressure and instruct your patient to hold and don't let you move them. Okay, hold, don't let me move you. Relax. Hold, don't let me move you. And relax.
Following the command hold, don't let me move you, patient has elbow and near end range extension and wrist in end range flexion. A force is applied to the hand to bring the wrist into extension while the patient resists. If test is positive, pain will be reproduced at the medial elbow. All right, just go and hold that right there and don't let me move you. And relax. Patient seated with elbow flexed to 45 to 60 degrees with the forearm in mid-range. Practitioner grasps radial head with a pinch grip and glides anterior to increase supination and posterior to increase pronation. Patient position supine with elbow flexed to 90 degrees. Practitioner's hands at proximal forearm close to the joint line. Forces a direct distraction following the plane of the joint at a 45-degree angle inferiorly towards the practitioner's hip. Force is put through the 5th digit on the active hand. Lightly tap on the carpal tunnel with 2 fingers. If test is positive, paresthesia, numbness, and tingling will be present in the first 3 digits of that hand. All right, I'm just going to tap right here. Let me know if this reproduces any of your symptoms. Have patient hold both wrists in maximum flexion by pressing the dorsal side of their hands together for 1 minute. Test is positive if paresthesia or numbness is felt in the first 3 digits. All right, so we're going to put the back of our hands together. And then we're going to lift our hands up right here. We're going to hold this for a minute and let me know if it reproduces any of your symptoms. Okay. Sweet. Position patient with hand just off of treatment table while stabilizing the distal forearm. Apply a posterior pressure to the proximal row of carpal bones to facilitate wrist extension. Stabilize the second metacarpal while grabbing the second proximal phalanx to apply a traction force to the second MCP joint.